to week 5, and we're in the middle of midterms now. Hopefully you guys are getting used to this online quarters and our online club, so thanks for joining us again. This week we're going to be going over eye movements and the midbrain. Let's go ahead and just get some announcements. So follow us on Instagram if you don't already. It's an easy way to get our links every week as well as just anything else we post. Subscribe to our YouTube channel so you can have easy access to these videos, and like the videos so you can find them. And then I posted a video on Engage, if that's where you follow us, that has the link to our playlist of all of the videos that we're posting throughout the quarter. So if you ever lose track of us, you can always go on Engage, download that document, and just keep it for you guys in your files. And another quick thing is I just wanted to thank you guys. Like I said, I know it's the middle of midterm, so if you've been keeping up with us week to week, I really appreciate it. I know it's been interesting, and being online for any longer than you already have to be is asking a lot, but it really shows with your dedication to learning and really becoming that doctor of the nervous system. And also, thank you to Roope for teaching every week with me and helping us to keep this thing going, because it has been interesting for all of us, but thank you guys. So our goals for tonight, I'm just going to do a quick review to keep you guys, highlight some key things that we went over last week, so that if you need the review, it's in this, this video as well, so you don't have to keep going back and forth, but it'll be brief. Then Roope is going to take over. He's going to go over BPPV, which is a common, common condition that we see as chiropractors. So we're going to look at it through a functional neurology perspective, learning what we know about the vestibular system from last week, and talk about treatment. Then we're going to go over the 6 eye movement. So shout out to Dr. Ellis. He was the one that taught us the specific order, and I think it works really well to help you guys learn these eye movements. And then we're going to do some V&G breakouts to help you guys see the actual eye movements that we're talking about and get some clinical testing so you guys can have a better idea. And then we're going to give you guys an introduction to the midbrain. We're going to take a deep dive into it a little bit more next week as well. When we start to get into cranial nerves, we're going to look at the whole brain stem. But today we're going to focus on just the midbrain, because we've been talking about it a lot with our eye movements, and just tell you guys what you can see and why you might, the clinical relevance of why you might want to use an ophthalmoscope or look into your patient's eyes, what a pupil response can tell you about your patient, besides just the basic cranial nerve test that we learn about it in neurological diagnosis. So hopefully you guys will get some more insight today. So quick review. Last week we talked about VOR and eye movements. We talked about the canals, and we really dove into which eye muscles, what are the 6 eye muscles, what are their innervations, and the pathway that they go through. Roope drew them all out. So if you guys missed that, definitely go back. That was a great week with a lot of good information. So this is just that basic drawing that we like to use of the brainstem. This is more of the anatomical view of the underside of our brain, showing us all the cranial nerves. So last week we were focusing on cranial nerves 3, 4, and 6, as well as our vestibular nuclei, to get that VOR pathway that we added in. So this week we're really going to be focusing on our mesencephalon, or our midbrain, which houses cranial nerves 3 and 4. And so this other picture is just something that I drew and I showed you guys last week, and I think it's just a helpful summary for you guys. So we talked about our VOR reflex, which is what gives us tied in our canal head positions and our different eye movements. So we know that our VOR reflex helps us to move our eyes equally and oppositely to the way we move our head. So this reflex, when we bring our head into the right anterior canal, so moose ears or no moose ears, if you look just straight ahead and move your head into the right anterior canal, your eyes are going to go up and to the right. So when they're up and to the right, my right eye is abducted, so my superior rectus is going to be fired, and my inferior oblique is the pairing for that. So it's my inferior oblique on the left is going to elevate my eye in adduction. So those two muscles are both innervated by cranial nerve 3. So for both of our anterior canals, when we're looking up and to the right and the left, we can think about really strongly activating our cranial nerve 3. our horizontal canals, we're adding in that component of the lateral rectus. So we're starting to get pontine activation with our abducens. So if I just turn my head to the right or to the left, my eyes would go the opposite direction as part of our VOR that we were talking about. And we're going to be using lateral rectus, medial rectus, 6 and 3. And then for our posterior canals, so bring your right head or your head to the right, and posterior, if you want to get into the right anterior canal, and you're looking down and to the left in that opposite position. And you're looking down, so if I'm looking down and to the left, my left eye is abducted, so I'm going to be using my inferior rectus on the left and my superior oblique on the right. In a deduction, my right eye is going to be depressed by my superior oblique. We talked about superior and inferior oblique being kind of funny, but we explained the anatomical positions of them and why they elevate and depress the eyes respectively last week. So if you need to review that, go ahead and do that before we get into this week. So, and then our posterior canals are going to be using cranial nerves 3 and 4, which are the cranial nerves housed in our midbrain that we're going to be talking a lot about today. And just another quick review that we'll talk about today, but just to remind you guys, with each of those canal positions, the right anterior canal, posterior canal, and horizontal canal are going to activate our right cerebellum, and vice versa, our left canals are going to activate our left cerebellum. So when we talk about the eye movements that are paired with our canals, we can talk about how eye movements can also work with our cerebellum. So if we want to activate our right cerebellum more, we can say we're going to go in this diagonal. So up and to the right, down and to the left, and then to the left. So if you want to remember it, you can think I'm going to look up to my cerebellum when you're talking about the diagonals, if you want to remember which is which. So then left cerebellum is the opposite diagonal. Alrighty, so I'm going to hand it off to Roope, and we're going to get started. Here you go.
All right, all right, thank you, Rebecca, for that great review on the vestibular system. Now we're going to continue our conversation with the vestibular system. I'm going to be talking about BPPV, which is the most common peripheral vestibular disorder. When we talk about peripheral versus central disorders, when I say peripheral, we're meaning that anything or a pathology or disorder that happens in the vestibular apparatus or in the vestibular cochlear nerve. Anything past that in the brainstem, in the vestibular nuclei or the cerebellum, is considered to be a central vestibular disorder. Okay? So when we talk about BPPV, it stands for benign paroxysmal positional vertigo, meaning that benign, it is not malignant, so you're not going to die from it. Paroxysmal, it comes and goes with sudden intensification of symptoms. Positional, your change in your head position is going to cause these symptoms such as vertigo. Vertigo meaning that you feel like you're spinning or you feel like the world is spinning around you. And you get associated symptoms with that such as dizziness, poor balance, nausea, and other autonomic findings or autonomic symptoms. And what happens in this disorder is that you have these little otoconia, these tiny crystals in your otoliths. They're weighing the gelatin membrane so that whenever you move your head in this linear translation way, you're going up or down, or you're going in the horizontal plane, or you're tilting your head, those otoconia are adding weight to that gelatin membrane so that those hair cells get deflected and you get the sensation that you're moving. Well, in this disorder, what happens is that one of those otoconia, one of those crystals or stones, will dislodge from the membrane and migrate into one of the semicircular canals. And most often, it'll be the posterior canal. I have it here, so it'll be 41 to 90% of the time, it'll be in the posterior canal. And when that rock migrates into the canal, remember that the canal has endolymph. So whenever you move your head in different directions, that endolymph moves with the canal, and it deflects the cupula and the hair cells to give you the sensation that you're moving. Well, if there's a rock in there, the rock, remember that the fluid, the endolymph, is really viscous, okay? It's like honey. And if the rock is in there and you move your head, the rock will lag behind the movement and it keeps deflecting those hair cells even though you are no longer moving. So if I go ahead and I move in this different direction, let's say I go ahead and lay on my back and I have a rock or otolith or otoconia in my right posterior canal, and I go ahead and go in this lying position, and I'm not moving anymore, but now the rock is still moving, and it's going to deflect those hair cells, and it's going to give me the sensation that I'm moving. So I get this huge vertigo, feeling like the whole world is spinning around me, and I will get all these autonomic symptoms because it will feel awful to you. Okay? And the reason why we actually teach this to you guys is because it's such an easy fix, and you're going to change the patient's life in one visit if you're going to be able to treat this, and it's super easy to treat as well. So like I said, a certain movement such as changing a position when you for example asleep might induce this vertigo. And the thing you want to understand, it usually takes about 30 to 60 seconds for those symptoms to occur. If you have a patient who comes in who feel like they're dizzy all the time, and no position of their changes or no positional change of their head is going to cause more vertigo or decrease it, you're most likely talking about a central vestibular disorder. But with BPPV, a change in head position will give you an sudden intensification of symptoms for about 30 to 60 seconds. And once the rock stops moving, there's no more afferentation coming through the vestibulocochlear nerve telling your brain that you're moving, and then it goes away. Okay? And if someone has had a head injury, it's more common that that person has a BPPV than that they don't. Okay? So it's really important that when you're treating concussion patients or even elderly people, that you take this into consideration. If a patient walks into your office saying that, yeah, I get vertigo really bad when I go from lying, when I'm lying, I go to my right side, or if I go to my left side, or if I'm picking up something from the ground, or any other change in head position, will give them 30 to 60 seconds of vertigo. You want to think about BPPV, okay? And when we start talking about how do we check and test for the BPPV, how to treat it, well, how to test for it, we're going to use the Dix-Hallpike maneuver. I'm going to show you with Rebecca how to do that. And with that maneuver, it's really important that you understand the dynamics of a nystagmus. So remember, a nystagmus is an eye movement that has a fast phase and a slow phase. So if I have a nystagmus to the left, that means that my eyes will drift to the right and have a fast phase to the left. Okay, slow to the right and quick to the left. So we named the nystagmus according or based off of the quick movement. All right. So if I would move my head to the right, my eyes would go slowly to the right, and then they would snap back to the left. So that would be a left beating nystagmus. Okay. And now in this case, when posterior canals are the most frequent ones to have this otoconia in them, let's pick a right posterior canal, for example. So if I have a right posterior canal BPPV, and I go in this Dix-Hallpike maneuver position, and don't worry, I'm going to show you this in a minute how to do this. I go in this position, and now though that rock keeps moving in my endolymph and deflecting those hair cells, what will happen is my eyes will go down and to the left, and then you will have a fast beating nystagmus going up and to the right. Okay, beating towards the pathological canal in this case. Okay. But if you only have vertical or torsional nystagmus in that position, you might be dealing with a central vestibular disorder rather than a peripheral vestibular disorder. So it's really important for you to be able to assess the direction of the nystagmus so you're actually treating the right thing. Okay? So then to treat it, we're going to perform an Epley maneuver. I'm going to show you how to do that. It's really simple, and if you do it right, you should be able to fix this patient in one visit. And one thing I really want you to understand, that if a patient has had a BPPV for a longer period of time, they might have some central consequences due to this peripheral vestibular pathology. And you just don't want to send them home after one visit. You want to be looking at their vestibular system, their function overall, after you fix the BPPV, and if there's anything else for you to fix, okay? Because there might be some serious central consequences there as well that you might have to address, okay? So right now I'm going to show you with Rebecca how to perform these maneuvers. And okay, let's do it. All right, so now we're going to talk about how to test for BPPV and how you treat it. So classically, we use the Dix-Hallpike maneuver to test for BPPV, and in this case, we're going to give Rebecca a right posterior canal BPPV. since the posterior canals are the most common for those otoconia to dislodge and migrate into, okay? But depending on which canal you have those otoconia in, is going to dictate which kind of maneuver you're going to do to fix it. But for a posterior canal, we're going to use an Epley maneuver to fix and move that otoconia away from the semicircular canal back to the otolithic system. Okay? So first we're going to start with the Dix Hallpike. So I'm going to have her sit right there, and I want her right here so her head will come off of the table, edge of the table. Okay? And if she has a right posterior canal BPPV, I'm going to have her turn her head to the right and then go ahead and lay down rapidly. Good. And then you're going to hold the patient's head here, and you're going to observe for nystagmus, okay? Now, if she has the right posterior canal BPPV, she should have a nystagmus for about 30 seconds or so. It can change and vary how long you have the nystagmus, but you're going to be observing for the direction of the nystagmus. So for a right posterior canal nystagmus, she might have a upbeating nystagmus up and to the right. So her right posterior canal would push the eyes down into the left, and then the eyes would rapidly have a quick phase into up and to the right, okay? So that would be a right positive or right posterior canal BPPV. Go ahead and sit up. Perfect. So now we have seen that she has an actual BPPV. Then we go into our Epley maneuver. So the Epley maneuver is done quite similarly. So we start with the same setup, and then we go ahead and rotate her head from side to side to side, and then we let her come sit up. So removing that little otoconia, that crystal, away from the canal. Remember that the canals are angular, okay? So we have to move her head through these different directions so we can actually have the otoconia move with the endolymph and back in the otolithic system. So go ahead and do the same thing. One sec, come back and move your, perfect. So move your head 45 degrees to the right and then come back. Come back down, perfect. There you go. Now you want to make sure that the patient's head is slightly off the tilt of the table, like this. And now same thing, you're going to be observing for nystagmus, and make sure you tell the patient that you might feel horrible. And they might actually throw up in this position because they might get so dizzy and they might get so much vertigo. And make sure you have a trash can next to you in case that happens. So now I'm just observing for the nystagmus and make sure the head is down here. And I'm observing if it goes away. When the nystagmus goes away, I go ahead and rotate the head in this direction to this another 45-degree angle, okay? Then the nystagmus might reappear, okay? And we're holding and waiting for the nystagmus to disappear. Once the nystagmus disappears, we'll go ahead and move her to the left side. We'll move her head another 45-degree angle, like that. We hold until nystagmus goes away, and then go ahead and sit up. Perfect. Cool. So that's how it's done, and make sure you have a comfortable position, because I didn't. So make sure ergonomically we might have a chair here, and then move their head in there. It's easier for you, okay? And also just make sure you are finding that the nystagmus is actually associated with that canal. So if she had a downbeating nystagmus or a vertical nystagmus or only purely torsional nystagmus, I don't think that would be a right posterior canal BPPV. That might be a central vestibular disorder. So you have to look at the direction of the nystagmus if it matches with the actual pathology of that BPPV, okay? And another thing just important to make sure is just to tell your patient that it will and it might feel really uncomfortable during the maneuver, but after the maneuver the patient should be free of vertigo, and there might be some central consequences that the patient got from this peripheral vestibular disorder depending how long they've had this BPPV. So make sure you check the patient's condition after the test as well, and you leave them with a stable functioning nervous system. Okay? Thank you. All right, so now we're going to start talking about the eye movements more in detail. And so the reason why functional neurologists are always looking at eye movements is because there's such a good window into their brain function. Okay, so the oculomotor system can pretty much tap into every part of the brain, and we can bias so many different pathways with our eye movement therapies to help our patients. And your treatments and your neurological assessments are going to get a lot more interesting once you understand the neuroanatomy and the function of these eye movements and how they play a role in your nervous system. So let's start talking about this. So we have these 6 fundamental eye movements that we always talk about. We have our pursuits, saccades, OPK, VOR, COR, and vergence. And I would also add gaze fixation into this list. And these first three, pursuits and saccades and OPK, we're going to spend some time talking about today. VOR, we already talked about last week, so you should have a pretty good understanding of what the vestibulo-ocular reflex does. The COR, the cervico-ocular reflex, is there to facilitate eye movements in response to proprioception to the neck or the upper cervical spine. And it is there to supplement the VOR. And oftentimes when you have a lesion to the vestibular apparatus, you'll see that the COR will be functioning. So the gain of the COR should be really low in a normal, healthy situation. But when you get lesions, the COR might kick in. Then we have vergence. So vergence is our only disconjugate eye movement out of these eye movements here. And what does that mean is that your eyes will move in different directions. So usually in all the other eye movements, your eyes are moving in the same direction. So they're conjugate eye movements. Your pursuits are same direction, saccades, etc., etc. But vergence, when you have convergence and divergence, your eyes are moving in opposite direction. So if I'm following a target that's coming close to me like this, my left eye is moving to the right, and my right eye is moving to the left. And then divergence, I'm looking at something further in the distance, my eyes will diverge, okay? And that's just something that to pay attention to. And divergence is a lot, it's a lot mediated by the mesencephalic area, so the midbrain, and also a big otolithic function as well. We're not going to discuss divergence too much today, but just to kind of give you an idea of what we're talking about here. So let's start talking about pursuits. So pursuits are there to stabilize the image of a moving target on your fovea. So let's say I'm trying to track an object that's moving in my visual field, such as a bird flying in the sky. My eyes are going to be following that target smoothly, and it tries to stay on the target, and the fovea is able to fixate on it. So it's basically just a series of gaze fixations on a target. And the thing is, you cannot pursue it volitionally without a target. So if I would try to pursue it right now from right to left without a target, I couldn't do that. I would just have the series of jumpy movements called saccades. Okay, so I have to have a target in order for me to have the smooth pursued eye movement. And the latency of that movement, meaning the time to initiation, is about 100 to 130 milliseconds. But it's still fairly fast system. But remember, the VOR was way faster than that, 7 to 15 milliseconds. But one of the main things I want you to take from this is that pursuits are controlled by the ipsilateral parietal lobe. So if I pursue to the right like this, my eyes are following smoothly to the right. That's controlled by my right parietal lobe. If I pursue to the left, that's controlled by my left parietal lobe. Okay? And I want you to remember from last week that horizontal eye movements are going to be more pontine. Vertical eye movements are going to be more mesencephalic, more midbrain activity. Okay? Then also remember the cerebellar planes. Looking up and to the right and down and to the left will be a right cerebellar activity, and looking up and to the left, down and to the right would be a left cerebellar activity. So you start biasing these different pathways and these different areas of the brainstem and the brain in your therapies. But remember, ipsilateral parietal lobe for ipsilateral pursuits. Okay, right pursuit, right parietal lobe. And then when you do an upward pursuit, we're talking about more mesencephalic and bilateral cortical activation. All right. So the gain is eye velocity divided by target velocity. So if you're following a target that's moving in your visual field and you're trying to follow it smoothly, well, we want to have your fovea being fixated on that target with a gain of 1 optimally. Obviously, you might not be perfect, but that's where we're trying to get at. So if the gain is decreased, let's say that your eyes are not going to be able to follow and they lag behind, you might have these saccadic movements are trying to refixate your eyes. I'm going to be talking about that a little bit more later. Or if you have increased gain, your eyes go past the target. Okay, so let's start talking about how we're going to test these. So what you're going to do is you're going to have the patient follow your thumb, and I'm going to show you with Rebecca just in a bit. Have the patient follow your thumb in the cardinal field of gaze, like this, and then you're going to do the cerebellar planes, just like that, and I'm going to show you. And then you're going to be looking at or observing for any break in smooth movement, such as jumping ahead of the target, which we call saccadic intrusions. So like I already mentioned, so if you're following a target and your eyes are jumping ahead of the target and then refixating back to the target, we call those saccadic intrusions. Then if you have you're lagging behind the target with possible catch-up saccades, so the target is moving here and I'm trying to follow it and my eyes are lagging behind, that's what we call catch-up saccades. Then we can have square wave jerks, meaning that you have quick movements in either in the same or opposite direction of the target, which way it is moving. And then just an inability to follow smoothly. So these are all the things you want to be looking at right now. Don't worry too much about the pathophysiology right now, because all of these areas are somehow related to the brainstem and the cortex, and we're going to dive a lot deeper into that in the advanced club. But right now, let's keep it simple and talk about pursuits, mesencephalon, the pontine areas, so you know which areas you're assessing over the other. Okay, so let's go ahead and do it. I'm going to show you with Rebecca with the VNG how it looks like. Alright, so now we're going to assess and test the function of the pursuit system. Okay, so first what I'm going to do, I'm going to do the cardinal fields of vision, and then I'm going to do the cerebellar planes, and then I'm going to do the vertical plane. Okay, so I just want you to remember that when you're looking at cerebellar planes, you're looking at one cerebellum over the other, vertical more mesencephalic, and horizontal more pontine. Okay, so what I'm going to do is I'm going to have you, Rebecca, follow my thumb. And now what's really important is that you're not in convergence when you're having her follow your thumb, or you're not too far away here. So you want to be in here in the normal functional position of the eyes. Okay, so you're going to follow my thumb without moving your head. So I'm doing horizontal first, and you're going to do the H letter here, cardinal field of vision, come in here. Okay, so you might have seen that little jump there. Then you're going to do cerebellar plane, so let's do the right cerebellum first. Left cerebellum. Okay, you might have seen those little jumps as well. So keep observing for her eye movements what happens. Then we can do vertical. So just follow the thumb. Okay, good. So now what's really important is for you to make sure that your thumb is staying on the horizontal and the vertical line, so you're not changing the depth of your finger when you're moving, going from side to side, or that your finger is not going vertically like this, because you might think that they have an eye movement problem, oculomotor control issue, even though they don't, when in reality it was just your finger that was moving. So try to keep it as stable as possible, so it's as easy as possible for her to follow it, and you're not creating any false pathologies in there. Okay, so let's look at them one more time, because we know that her pursuit system is actually not exactly the best. Okay, and then let's check the age again. Okay, a little jump there. Alright, so what you want to do in this case, if you saw that it was better on the left or worse on the right, you might start looking at other parietal lobe findings on the left side of the body. So you could do point localization, for example, on the left side of the body, and check if you have any other parietal lobe findings associated with your pursued eye movements. Now remember, if she pursues to the right, that's the right parietal lobe activity. If I pursue her to the left, that's a left parietal lobe activity. So then you start putting more tests together and seeing if it could be a cerebellar thing, not activating those pursuit pathways, or it could be an actual parietal lobe issue. So you just add more tests and see what makes the most sense and what neuraxis you might have to treat, and then you pre-check and post-check with the therapies and see if you could make a change to her eye movements. Okay? Alright, so then let's talk about saccades. So saccades are fast ballistic eye movements when your eyes move from one target to another target. So if I'm looking at my right thumb here and I want to look at my left thumb here, my eyes would jump from target to another target like this. So it's a fast ballistic eye movement, and it's one of the fastest movements you have in your body. Okay, and it's directly correlated to how far the object is. So if the object is a little bit farther away, the eye movement will actually be faster from here to here rather than from here to here. Okay? And you do about 100,000 saccades per day. So that's a lot of saccades. And I mentioned already in week 1, imagine if you have a faulty saccade system and you do this many saccades per day, that's going to take a lot of brain power to fix those errors that are happening every time you move your eyes from object to object. And remember, when you're reading, you're doing a whole bunch of saccades. So if you're trying to study and you get really fatigued, you might have an issue with the oculomotor system, specifically the saccades. So we have to test for this and see how their saccadic system is working. And what you want to really understand is that volitional saccades are generated in the contralateral frontal lobe. Okay, so if I'm looking into the center right now into the camera and I move my eyes to the left, that's generated by the right frontal lobe. Excuse me. So then if I move my eyes to the right, then you're going to be generate that saccade from the left frontal lobe. Okay, left saccade, right frontal lobe, right saccade, left frontal lobe. And then remember, pursuit was ipsilateral parietal lobe. I follow a pursuit ipsilaterally to the right, will be parietal lobe, and I saccade from right to left, that'll be a right frontal lobe saccading to the left. Okay, really important to understand that. And the latency here is about 150 to 200 milliseconds. So with our VNG machine, we can measure this really well. And usually when we talk about latencies over 250 milliseconds or 300, we're talking about increased latency. And then we start talking about different areas of the brain that are responsible for that cause of increased latency. All right, so then let's go ahead and start talking about how do we test this. So like I said a little bit already with the thumbs, have the patient look at your nose and place your thumbs 20 degrees from the patient, center of the vision, and instruct the patient to look at the thumb you move as quickly as possible, and then tell them to stay on that thumb until you tell them to go back to your nose. And I'm going to show you this with Rebecca how to do this, but here are just written instructions for you guys. And what you're going to be observing for is the latency that we already talked about, and also the speed. If you can see a slow saccade, it'll really be a slow saccade. And then because they're so fast that you're not supposed to see a slow saccades. And then metria, we're talking about if you're actually able to hit a target. Okay, so if my object is here, my eyes are here, and I'm moving from the center to the left like this, am I actually hitting the target? Are my eyes, my fovea, centralized into this target or not? Or did I overshoot the target, or did I undershoot the target? Okay, so if I undershoot the target, my target is here, eye movements are here. This is what it would look like. I would come boom boom. I would have 2 steps like that. And overshoot would be able to go over the target and then fixate back to the target. So undershoot, overshoot. Undershoot is called hypermetria, and undershoot is called hypometria. Okay. So when we talk about metria and dysmetria, remember that we talked about that with the cerebellum. And this is usually a lesion in the cerebellum when you see these dysmetric movements with the oculomotor, or even just dysmetria in the finger to nose and other cerebellar testings. But when we talk about hypermetria and hypometria in saccades, if you have hypermetric saccade, that's usually a vestigial lesion. And remember, we talked about the vestigial nucleus, which is one of the deep cerebellar nuclei that's in the very midline. So you remember, fat guys eat donuts. Okay, so it was the first deep cerebellar nuclei we discussed week 2. Then if you have a hypometric saccade, we usually talk about having a lesion in the dorsal vermis. Okay, the vermis was the very midline area of the cerebellum as well. Okay, just something to consider. So now I'm going to show you with Rebecca with the VNG again how to do this. Alright, so now we're going to talk about saccades and how we test for them. So, like I instructed you earlier, what you're going to do is you're going to have the patient look at your nose, and then what I want you to do, Rebecca, is when I flick my finger or wiggle my finger, I want you to look at that finger and stay on it until I tell you to go back to my nose, okay? Nose. 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 Very good. And now you can do the same thing vertically. Look look at my nose, and when I wiggle, nose, nose, nose. Very good. So again, you're looking at latency, speed, and metry of the saccades. So if you're actually able to hit the target, or if you're undershooting, overshooting, things like that. And we talked about a little bit about the pathology, why that might happen. Oftentimes overshooting and undershooting is associated with a cerebellar lesion. And then you're looking at the frontal lobe action as well. So are they actually able to generate a saccade to the contralateral side? Okay, so remember, a left saccade was a right frontal lobe activity. And then you could do these saccades as well in the cerebellar planes. And then we have what's called anti-saccades. So anti-saccades are pretty much the same thing, but this time what I want you to do, Rebecca, is I want you to look at the opposite finger that I flick. Okay, so if I flick here, I want you to look here. And then stay on it until I tell you to go back to my nose. 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 Really good. So in the anti-saccade, you have to have a volitional command telling you that I have to inhibit my eye movement where I was originally thought I would have to go to and go to the other side. It's a lot of prefrontal and basal ganglionatic activity in there. And when we talk about this anti-saccade versus saccades, remember that you can now start thinking about whether it's more mesencephalic, more pontine, frontal lobe activity, and then add the pursuits in for parietal lobe function as well, and start putting these tests together, okay? All right, so now let's start talking about the optokinetics, or the optokinetic nystagmus or reflex. So like the name says, they're non-volitional eye movements that are present in all humans, and they develop at the age of 6 months or so. And what the optokinetic really is that it's a combination of a pursuit and a saccade. So you have a slow phase eye movement and a fast phase eye movement. So imagine if you're in a car and you're driving 60 miles an hour, doesn't matter how fast really, but the trees are moving, and the trees are moving to your right, and you're looking out the window. Your eyes will follow those trees that are passing by, and then your eyes will automatically, reflexogenically saccade to the left to refixate your center of vision back to the center. And that's what it is. So you have a pursuit and a saccade, pursuit and a saccade. And the reason why we are so interested in this eye movement is because we can use this OPK to bias different activities in the brain, such as one hemisphere over the other, and we can also use this to rehabilitate a faulty pursuit system or a saccadic system. Okay, so somebody might have bad pursuits, but me pulling an OPK strip, I'll show you, such as like this, which has right and white stripes like this. Me pulling an OPK strip, for example, to the right, will have me pursuit to the right and saccade to the left. And normally, if I do a pursuit to the right and I have a bad system, you might be able to choose that system a little bit more with a reflexogenic eye movement and rehab that area of the brain to have a better outcome, a better motor output of that oculomotor system. Okay, and I'm going to show you in a bit how to do all that with Rebecca. Okay, so that's really important. And now, if I pull the OPK to the right, my eyes will pursue to the right and then saccade to the left. So a right pursuit is a right parietal lobe action or activity, and a left saccade is a right frontal lobe activity as well. So you're biasing one hemisphere over the other when you're doing these OPK activities. And also the OPK is really important in integrating the vestibular system, and it fires into the rostral fastigial nucleus as well, which has a lot to do with where our head is in space. So this is truly a really good therapy or a tool in your tool bag you can use to rehabilitate different areas of the central nervous system. Okay, also really important just to check if they have a normal optokinetic response. So when I do this with Rebecca, I'm going to do this optokinetic in different directions. So I want to do in cerebellar planes, in diagonals, and also in horizontal. And then you can just do vertical as well. And I'm going to show you now how to do this. Okay? Alright, so now we're going to start talking about the optokinetics and how we test for the optokinetic reflex by using the optokinetic strip. And we have these red and white stripes in here. So whenever I pull this optokinetic strip to the right, Rebecca's going to be following those red stripes with her eyes and pursuing, and then when new target appears, she'll saccade to the opposite side. So let me show you what it looks like. So she's going to be staring at this strip, and I'm going to pull the OPK to her left first. And you can see that reaction happen, that optokinetic nystagmus from the camera. So I go left, I go right. Really good. And you want to make sure, again, you're not changing the depth of how you're doing it. You're not too close to the patient. And you're going to be observing for the slow phase and the fast phase. Was there an increased time for the slow phase? Or was there a decreased time for the saccade, for the fast phase, or opposite? Okay, so you're looking at the gain of this whole system. And the same thing, you can do this vertically, diagonally, and horizontally. So if I would do this vertically, I have my watch on my wrist right now, so it might be a little difficult, but we're gonna try it. So vertically, her eyes are gonna move up slow and then jump back down. And then same thing, when you go down, eyes will follow slowly down and then saccade back up. Okay? And this would be a really bilateral mesencephalic and frontal lobe activity by doing a vertical OPK. Remember that we have pursuits going up and saccades going down, or the opposite. Okay? And then diagonally, we can also do this in the cerebellar planes. And then horizontally, we're going to have a bias towards one hemisphere over the other and more pontine activity rather than mesencephalic activity. So that's how you can start playing with the activity through the optokinetic reflex, and your brain rehab is going to get a lot easier and more functional. All right, so let's start talking about the midbrain, or the mesencephalon. It means the same thing. So the midbrain is a really primitive part of our brain, and it's the most rostral part of the brain stem. So when you see medulla, pons, and then the midbrain, that means that the most rostral part will be the midbrain. So some of the physiological functions I've listed here, but when it comes to the midbrain is this animalistic part of the brain. When you're talking about things like anxiety, paranoia, rage, you might be dealing with a hyperactive mesencephalon. Also, the mesencephalon has parasympathetic control over the pupil constriction, so that's something we're going to be discussing a lot, and I'm going to show you when you do a pupillary light reflex what to expect, and if the central integrated state of the midbrain is not doing that well, what you might observe. Also, the mesencephalon activates the IML contralaterally. So the IML is the intermediolateral cell column from T1 to L2, which is classically our sympathetics. And in just a bit, I'm going to show you why I have the contralaterally in quotes there, and I'm going to show you how it's organized in this neuro flow chart, so you understand how the activation of the IML happens. So then it's also responsible for controlling sleep and wake cycles. So you might have a patient with insomnia, and that could be possibly a mesencephalic problem. Also, pain modulation is an important part of the mesencephalon, so that's your endogenous opioid system, your analgesic system. So then, let me show you the neuroflow chart. So here, I hope you can see me. So we have the right mesencephalon there, and then the left mesencephalon. So when I said that it activates the IML, the sympathetics contralaterally, you can see here, you can follow the arrows, so the right mesencephalon fires into the left IML. So you might have more sympathetic findings on the left side of the body, such as cold and clammy hands. You might have increased blood pressure on that side. You might have pupil changes as well. And the thing you want to understand is that the right mesencephalon gets activated by the left cerebellum, and then the right mesencephalon communicates with the right cortex. And now why we said that the mesencephalon fires in the IML contralaterally is because once the activity from the left cerebellum, right mesencephalon, right cortex, comes into the cortex will fire into the PMRF, and the PMRF will inhibit this side of the IML. So you end up with cancellation of IML activity from this side of the mesencephalon. Okay, so that's why we classically say it'll activate the IML contralaterally. And you don't have to worry about all the other stuff right now, because we're going to have another week just discussing the autonomics, and then you start really putting this thing together. By the way, I want to introduce this concept to you, so it'll be much easier for you to understand Alright, so then some of the important nuclei that we have in the mesencephalon. We have the superior and inferior colliculi. So the superior and inferior colliculi will take in visual and auditory input and have reflexogenic eye movements and head movements towards that stimuli. So the superior colliculus will take in visual input in, and it will cause your eyes to move into that visual stimulus, and then possibly move your neck as well. And then the inferior colliculus will react to auditory stimuli. So these are classic here tectospinal reflexes. If there's a loud bang next to me to my right, I normally reflexogenically move my eyes to the right to see what's in there. And this is a protective mechanism, because in evolution, if you had a loud noise or you had something moving in your periphery when you're hunting and gathering, there's a great chance that that might have been something dangerous. Okay, so you have to have this reflex so you can actually see whether it's a danger or if it's not. If it's not a danger, then your frontal lobes kick in and tell you, okay, we don't have to worry about, we can lower their heart rate, we don't have to run away and flee. Okay, so then we have the cranial nerve nuclei, 3 and 4, that we already talked about last week. I hope you remember that they are in the midbrain. And then we have our Edinger-Westphal nucleus. And that's all about the parasympathetic pupil constriction that we're going to be discussing in just a minute. And then we have our red nuclei. So our red nucleus forms the rubrospinal tracts. And when we talk about the rubrospinal tract, we usually talk about proximal flexors of the arm. So we're looking at arm swing, okay? So these two, the Edinger-Westphal nucleus and the red nuclei, are going to be the ones that we're going to be assessing for the central integrated state of the midbrain, because they're so easy and fast to check for. Then PAG, we have the periaqueductal gray, which is about pain inhibition. Alright, so like I mentioned, two areas that we're going to determine this central integrated state of the midbrain. And remember, the central integrated state means that how close a neuron or a neuronal pool is to the threshold. So how much stimulus it takes to fire that pathway. And the red nucleus and the rubrospinal tract is kind of like our indirect corticospinal tract. So when you have an arm swing, when you're walking, we want to be assessing if you have a decreased arm swing on one side or the other, or increased arm swing on the other side. And then also we talked about this with the frontal lobe. So when you do a dual task, when somebody's walking or doing their gait, you can see if they are relying more on the subcortical region, such as the red nucleus, more than the frontal lobe, and see if those arm swings come about or if they get worse. Then we have the Edinger-Westphal nucleus, which is for the pupillary light reflex, and we're gonna be talking about that more in detail in just a bit. But here I have a drawing for you showing that the cortex firing into the same side of the red nucleus with the midbrain, firing down the opposite proximal flexor of the shoulder for giving you this arm swing. Okay, so examining the eyes. So we talked about the eye movements quite a lot. We talked about the pursuits, the saccades, the OPK, the COR, VOR, and divergence. But now we're really just looking at the eyes and seeing what there is to see. So first thing, you want to look at the pupils and observe for asymmetries. So if one pupil is more dilated than the other, or the other one is more constricted than the other, and we call this the anisocoria, meaning that there's a difference in size of the pupils. Then if there's a pathologically dilated pupil, we call that chorectasia or mydriasis. And if there's a pathologically constricted pupil, we call that chormiosis or miosis. There are different terms you'll find, so just try not to confuse those together. Then we want to look at pupillary light reflex. We want to perform both direct and indirect, and I'll show you that just in a bit. And then you want to look at the eyes and observe for ocular misalignment. Okay, so you're looking at the patient's eyes and you're seeing they're actually aligned in the center, or is one eye more to the left, or more to the right, or if it's adducted or abducted, or it's elevated than the other one, or you might see hypertropia, one eye higher than the other, and one might be hypotropic, lower than the other, or you might even see torsional movements of the eyes. Okay. And all that stuff, all the analysis about the ocular misalignment, we're going to be talking more in the advanced club. Alright, so then next you want to look at the lids, so the eyelids. Are the eyelids actually elevated bilaterally normally? So you're looking at asymmetry as well. If the eyelid is drooping, we call it a ptosis. And there are two important muscles when it comes to the eyelids. So the smooth muscle of Miller, which is innervated by the sympathetic nervous system, and then we have the levator palpebrae, which is innervated by the cranial nerve 3. And the cranial nerve 3 and the levator palpebrae are really functional together. They function together really well because they share a lot of axons. So the reason why that is, when you move your eyes up, your eyelids have to come up in order for you to see your upper visual field, okay? So then you can do an eye movement, a vertical eye movement, and see if their eyelids are actually raising. And also you want to compare the eyelids at rest, whether there's ptosis from one side to the other. Alright, so next you can use an ophthalmoscope and look at the VA ratio. So the VA ratio is the veins to arteries ratio. And usually we want it to be around 1.5 or 2 to 1, okay? So what it's talking about is the diameter of the veins to the arteries. And it should be 2 to 1 for veins to arteries. And these are the arteries that branch off of the central retinal artery in the back of your eye. So you're going to take the ophthalmoscope and look in the back of the eye and see if there's a difference in the diameter from veins to arteries. If there's an increased VA ratio, we usually talk about somebody having overactivity in their sympathetic nervous system. So when you have a hyperfunctioning, or if you have increased sympathetics, what will happen, you have more vasoconstriction of those arteries, and then you increase the VO ratio. And it's also really good for assessing the cerebral vascular integrity as well. And then perform pursuit, staccato, and OPK, and you guys already know how to do that. Alright, so then let's talk about the light response and what happens when you shine a light into your patient's eye. So let's say I shine a light into this patient's right eye. That light information, those action potential, will travel through the optic nerve and through the optic tract into the pretectal nuclei in the midbrain, and then it'll fire from the pretectal nuclei into the Edinger-Westphal nucleus. Remember when I talked about that? And then the Edinger-Westphal nucleus will fire into the ciliary ganglion, and the ciliary ganglion is a parasympathetic one, and it'll constrict the pupil to prevent excess light coming into the eye. Okay? And now I want you to also look at that. If I shine a light in this right eye, that information also travels into the left pretectal nucleus. But then also the pretectal nucleus communicates to the other pretectal nucleus on the opposite side. And that's why we do a direct and an indirect light reflex. Because if I shine a light here in this right eye, my left eye should constrict the same way as the right eye. Okay, because of this bilateral connection between the two. Alright, so then let's start talking about looking at the pupils and shining a light and what you might see functionally. So in a normal situation, when the central integrated state of the midbrain and the Edinger-Westphal nucleus is normal, you should see a rapid constriction with a normal time to fatigue, about 3 to 4 seconds, if you keep shining the light in the eye. And if you have a short-term TND, so transneural degeneration of the Edinger-Westphal nucleus, you might see an extremely rapid constriction followed by a relatively quick dilation. And why is that? I want to make the sense for you. Okay, so if you have extremely rapid constriction in TND, in transneural degeneration, what usually happens is that neuron becomes closer to the threshold, and it takes less and less stimuli to activate that pathway. And now when you shine a light into that TND Edinger-Westphal nucleus, you get really rapid constriction because it's already so close to threshold, and it doesn't take a lot to get that constriction. And then you have relatively quick dilation through the sympathetic nervous system. But here's the thing, if you have a long-term TND of the Edinger-Westphal nucleus, that neuron has been so close to the threshold for so long that it cannot withstand the amount of energy it's supposed to supply to that system, and it starts fatiguing and failing. So now, when you shine a light into this long-term TND Edinger-Westphal nucleus, you see slow constriction and quick to dilate with a possible hippus. So slow to constrict because it doesn't have the energy or the ATP to activate that system, and you don't get a lot of constriction. Okay? And then you might see the hippus, which is this fluctuation between dilation and constriction, which is classically seen in a long-term TND of the Edinger-Westphal nucleus. So I hope that makes sense to you. And next I have a picture for you showing you an anisocoria. So this is pretty extreme. So we have a correctatia or a chormiosis on the left. So greater pupil here and smaller pupil there. So if you would shine a light, or before I talk about shining a light again, what you're looking at here is you're looking at either you have increased dilator muscles, so increased activity coming from the sympathetic nervous system, or you have low firing constrictors. Okay, so you don't know which one do you have yet. So now if you shine a light into this eye that has increased size of the pupil, and you have a really slow response and slow fatigue, we're usually talking about increased sympathetic activity. And then the other ones you already know we discussed from the Edinburgh vestibular nucleus. So you want to start thinking about these presynaptic pools. Could it be sympathetic? Could it be the midbrain? Okay, and this light reflex is a really good window into looking at the central integrated state of the midbrain. All right, so that's your way of looking at it. And then also, when we talk about the Edinburgh vestibular nucleus, you want to start thinking about, okay, well, what is connected to the Edinburgh vestibular nucleus? What is the presynaptic pools? Well, that's going to be the ipsilateral cortex, the ipsilateral basal ganglia, and the contralateral cerebellum. So then you start looking at, well, do I have any cerebellar findings? Do I have any cortical findings associated with this pupillary light reflex? Or do you have any basal ganglionic findings, which we haven't talked about too much yet, but you might see twitching of muscles on the contralateral side, or you might see tremor or involuntary movements, things like that. So that's kind of like your differentials when you start looking at these light reflexes. All right, so that's pretty much all we have for you guys this week. Hope you enjoyed it, and we'll see you next week.